Thank you for coming today to our research seminar given by Laurie Curtis in the Department of Economics at the University of Waterloo. Laurie talking about utilization of online health information, a Canadian study. I'm looking forward to this presentation because we're very involved with developing new systems, and so it'll be interesting to see what her results are saying about the usage of systems and how we can maybe make our systems better. Before we start, and before Maher introduces our speaker, I just want to inform people about another seminar that we will be holding 2 weeks from now in the room next door, 1302. It will be given by Mr. Tom Clausen. Tom Clausen is a healthcare management consultant, and you may know of him as in his former position as president and CEO of the University Health Network in Toronto. He has instrumental in working with the emergency departments of both Grandeur Hospital and St. Mary's Hospital. Has been doing some very interesting work there. We're very pleased that Tom will be speaking at our Why Not Smarter Health Seminar Series, 3 p.m. on April 25th. He's talking on why not create the ideal system for health informatics. So it will be a very interesting talk, and I invite you all to come. So with that short announcement, here will you please introduce our speaker?
Good afternoon, everyone. It's my pleasure to introduce our guest speaker today. Laurie Curtis is an associate professor of economics at the University of Waterloo and the Canada Research Chair in Health Economics and Technology. Laurie is currently setting up the Waterloo Health and Economics Data Laboratory and is active member of CDAP, the Social and Economic Dimensions of an Aging Population Research Program. Laurie's research interests are health economics related to social policies, social determinants of health and healthcare utilization, and labor economics related to social policy and health. Today, Laurie will talk about the utilization of online health information and healthcare utilization, a Canadian study. Welcome, Laurie.
Thank you. Thank you for inviting me, and I'm glad to be here. As was said, I think, a couple times now, my talk is about utilization of health information, a Canadian study, because we have a couple of unique data sets that really aren't available in general. My co-author is Xuzhen Zhang, a former master's student in our department, and also now is employed in the department I used to work at before I came here. So we thank Charles Mallory, Magali Bruchot, and Ariane Giroux-Denis, I hope I said those right, for their valuable inputs to the work. And then for the use of these data, Earl Berger from a healthcare consulting group and Jay Armstrong from Environmentics Research Group. These data are proprietary data, and they're available through Health Canada because Health Canada purchases them. So I actually have never seen the data. I only get to look have some input into what analysis needs to be done, and then I get to see the results. So, and then all interpretations are our own. Health Canada doesn't have anything to do with the interpretations, and any oversights are the responsibility of the authors. So having said all the stuff I need, oh, that's not good.
That was quick.
Wow. Okay, let me see. I think hopefully I pushed end instead of page down. Yes. So a little bit of background. Over the last decade, I think as we all know, I know because I don't have to go to the library anymore, the internet has become an increasingly important information distributing channel. Particularly in health, Canadian governments are putting a fair bit of money into, and so are other health organizations, into maintain health-related websites, providing information on styles, healthcare system, disease prevention, community health programs. Just about anything related to health is out there. Some not good websites. But for a couple, the Canadian Health Network and the Health Canada's official website. And provincial governments are also doing the same, and a couple of provincial websites there, Healthy Ontario and BC Health Guide. And the reason we have BC Health Guide there is they're doing a lot of work on waiting lists, trying to get waiting list information out to the public. See if I can do this right this time. Yeah. So basically, an increasing proportion of the population is exposed to the internet. 60% of Canadian households have an internet connection, which is up from, that was in 2004, which is up from 40% in 2000. So that's a huge increase in the number of households that are actually online now. And then once individuals have access to the internet, like I said, vast amount of online health information. So this is expected to have some impact on the healthcare system. The governments in general are hoping that it promotes more use of preventative of medicine, less use of sort of non-necessary kinds of medicine. However, there may also be an inverse causality there. It may be that the healthcare sector is causing an increased use of the internet. So if you're having problem finding a doctor or you're having problem getting an appointment to see a doctor, you may go online to find out what information is out there. So what's out there? There's actually, we started this, oh gosh, I think about 2.5 years ago. There wasn't a lot. And then as we've sort of begun to write it up, we've been doing more searches, and it's just amazing how every month you do a news and there's more stuff. So previous literature looked mainly at the individual characteristics of the online health information utilizer, but very few looked at any how that intertwined with the health character. Studies examine the impact of online health utilization on healthcare, but basically the results were mixed. Some of the results show that informed individuals make better estimates of the productivity of medical care, so they make better decisions about using it, especially for preventative care. And then a couple studies, Wigner and Greenlick, 2001 in particular, reported that parents use the internet for pediatric health care, and that seemed to decrease pediatric consultations. So some more recent stuff, and a lot of this is from social science and medicine, because they seem to be focusing, because it has both the medical factor and the social science factor, they seem focusing on, or at least seem to be the journal that's doing a fair bit of publication in this area. The thing is, a lot of the research is coming out of the U.S. So Cotton and Gupta, 2004, Social Science and Medicine, looked at the differences between characteristics of on and offline information seekers with a small subsample of the 2000 General Social Survey in the U.S. There was a module about internet health behavior. And the results indicate that still the majority of both on and online users prefer to seek the information from healthcare professionals. However, several key factors, age, income, and education, discriminate between on and offline users in the U.S. So the digital divide, which I'm sure people are familiar with that term, basically those that are better educated, have higher incomes, and are younger, use the internet or use technology in general a lot more than those who are not. So this digital divide also influences the source of health, where people get their health information. And also their study found that those who were healthier and happier, which again is usually correlated with SCS, were less likely to exclusively offline for health information. Oops, I did it again. Okay. Berger et al., 2005, examined patterns of internet use among those with stigmatizing illness. So they kind of thought, well, if our individuals who are going for healthcare information, it may be those that are a little embarrassed about diseases and don't actually want to talk face-to-face with people. So they're stigmatizing illnesses, depression, anxiety, incontinence, and herpes. So those were the groups they used. And respondents who reported these types of illnesses were compared to other people with chronic illnesses. So they wanted to compare both people having illnesses with different illnesses. The multivariate analysis indicated those with stigmatizing illnesses were more likely to have used the internet likely to have communicated with a physician over the internet, but not in the last year, but not in the last. So it was a frequency thing, but it was a use or not use thing. In the U.S., I guess it's you can access a physician over the internet in some cases. I don't think this is used a lot in Canada yet. So basically, those with stigmatizing illnesses were more likely to report that they increased their utilization of health care once they used the internet, got some information off the internet. And basically, it was the psychiatric stigmatizing illnesses that were driving the results. Those with incontinence or herpes didn't seem to be any different than other chronic illnesses. So they suggest that the internet may be a valuable health communication and education tool for these populations. Hopefully you can see that way down there. I like this study a lot because maybe I do a lot of on women's issues. So Pandya et al. Looked at the question of why women use the internet for health information. And the other reason I liked it is they actually put out some models. They wanted to look at developing some explanatory models of why people might use the internet. So they had the health and wellness model, which sort of postulated that women who are health conscious and trying to seek out health information to improve their health just use the internet as another tool. The health needs model said that those who are actually ill and want information then go out and use the internet. And then the search cost model is more like an economic model economists would identify with. It's basically that health information, getting health information is viewed as costly, and the internet actually reduces the cost of searching for information. So they used a random digit dial telephone survey of 3 counties in southern New Jersey, women of over the age of 18. And so, of course, it has all the problems of being a telephone survey and being from a small area, but they claim it was kind of representative. So, again, doctors were the most sought-out source of health information. That doesn't seem to be changing in any of the studies. But women are increasingly using the internet as a supplement, and it was motivated by several factors. And a lot of the studies showed that women actually use it more than men for health information, which I was kind of surprised about. So health-conscious women more likely to use the internet for health information, so therefore the health wellness model seemed to pan out. But there was also some evidence that health needs and high-cost information were also motivating factors. So all 3 models worked a little bit, but the health information model seemed to work the most. And search cost model indicated that it wasn't large distances to go to the physician that were driving women to seek health information, but it was just their busy lifestyles. So women that worked and had other kinds of obligations tended to use the internet more than those who but traveling long distances from healthcare providers wasn't significant. So they found 2 key policy findings. Again, the gaping digital divide. They found an internet of 20% between higher SES and lower SES women. And again, this strong indication of use for health promotion. So they believe that policies to sort of bridge this digital divide would also have a positive impact on health promotion issues. So if you could get rid of the digital divide, you would actually increase people's users of health promotion. So it's sort of a little bit more on the economics line, as suggested by Grossman way back in 1972. Demand for health is derived, and health information is the same, because we want information on health. If we want to produce health, we need to either use healthcare or the health information to do that. So using this model, where it all analyzed the demands for health information from different kinds of sources, medical reference books, telephone advice from nurses, and the internet. And their findings indicate that the demand for health information, again, is sensitive to time costs. However, typically, ownership of a computer and having access to the internet were found to be associated with higher use of internet gathering health information. And it's not just having access to the internet, like you can go to the library and use it, it's actually owning one in your home, because it's kind of a private thing. All 2004 uses a similar framework, again, to take in both and determine a demand for health information, focusing on the internet. So he looked at individuals with chronic conditions, assumed to have higher benefits from seeking out health information, and those with higher costs in obtaining professional health care information, so those that had higher paying jobs, etc. Or just had a harder time in getting information from the traditional sources. Both groups tended to use the internet more to obtain health information and communicate with others about health than those that didn't have chronic illnesses or those that didn't have high time costs. So again, this is all seems to be very logical. Again, some more studies on, recent studies on socioeconomic status and the use of health information. Basically, studies indicate that those over 65 are less likely to report internet use, and those over 75 very rarely report internet use. This could be, some studies talk about lack of enthusiasm, others talk about studies talk about lack of skills to use the internet, and therefore this kind of ties back into the there really wouldn't be any savings, search cost savings, because if you don't know how to use the internet, it's going to just take you 3 times as long to find the information as others. SES, again, better education, higher income. Better educated, higher income individuals are more likely to use the internet, and that comes up study after. In mixed literature, we talk about education being correlated with higher marginal productivity of the information. Also may be correlated with lower time costs because you actually know how to use the internet. As well, low income is with low literacy, and this could be a barrier to use. I must have taken it out. One of the studies indicated that to actually use health information on the internet, you had to have skills of at least a grade 11 student. So if some of these individuals don't have that, then they can't use the information. And then again, those with higher needs, healthcare needs, to the internet more. I've said enough on that. Problem is there seems to be limited use of the internet health information. So there's all this stuff out there about saying sort of who uses the information. The problem is it's not getting used as much as people had hoped it would. So there is, as I showed you in one of the very first slides, there is an increasing trends towards using the internet. However, utilization of online health information seems to be more limited. Again, from the U.S., in 2002, about 38% of consumers reported looking for health information on the internet. but oddly, only 16% identified the internet as a source of health information. So it's kind of at odds that people are looking for info, but they don't report it as actually a source. And even, the people, it's only about 40% of the population who are looking on the internet. And then those who actually use the internet for health information use it infrequently. About 78% of those who did use the for health information only use it every 3 months. So it's not so regular thing. This slide talks about, again, having a computer and access is the strongest, or home access is the strongest factor. Low literacy skills is a problem. The other problems are sort of from the supply side is the internet's low cost of production of information may lead to information over. Studies have looked at the reliability of information out there, and Weiss and Moore and all found that the overall quality of web information on osteoporosis was poor, and also on the study on looking at information on IUDs. And it's also, the more information that's out there, it's even for individuals who are quite familiar with the internet, it's harder for them to synthesize all the material and sort of decide what's good and what's bad. So having you a general look at the what literature is out there. I'll actually switch to our study now. So our study, from a Canadian context, again looks at what characteristics are associated with the use of the internet, and we do use of info. We do it only conditional on those that actually say they use the internet. So we look at the characteristics of use, no use, and then conditional on having used the internet or being an internet user, what are the conditions, the characteristics of people that look for health information on the internet. We add an indicator of the healthcare system into the analysis as unmet healthcare needs. So do people who identify or self-report that they have unmet healthcare needs, do they use the internet more than those that do not report this? The other thing we wanted to look at, because in general governments are interested in lowering the cost in the healthcare system, so does the use of online health information increase or decrease healthcare utilization, notably physicians' visits? And the other important thing is do people that use online health information feel better informed? Okay, so there's a lot of information about whether people use it or not, but there's not a lot of information about, do they actually feel that it's productive? So we use two unique data sets. As I said, in the Canadian context, we examine the characteristics of an individual use. I just said all that. Okay, so the first data set that we use is the Berger Population Health Monitor Survey, and it's a proprietary data set that's been in existence since 1988. They started to include information on internet use in 1999, and it's classified by Health Canada now as the largest non-governmental syndicated survey of the healthcare sector in Canada. Again, phone interviews, so all the problems with phone interviews, but that's what you have. For people 15 years and over, living in the 10 provinces and the 3 territories. We use 3 cycles. Cycle 27 was the most recent one, from April to September 2004, about 4,100 observations. Cycle 24 to 26 were completed over the year 2003 with about 9,000 observations. So we pooled to get a large data set. We pooled the 3 studies, and we control for a year. And the information collected on health status, healthcare utilization, health behaviors, internet use, and demographic variables. And the data are all, at least were all verified to the 1996 census and are weighted. So the questions we specifically look at is, have you personally used the internet in the past 6 months? In the past month, have you used the internet for anything to do with health, including finding information on medical conditions, alternative remedies, or buying something health-related? And then over the last 12 months, were you or members of your immediate family ever not able to obtain health care services? So you'll probably notice immediately that the first problem is our time frames don't really line up. We've got information about the internet use in the last 6 months, information on health internet use in the last month, and then information about healthcare use or unmet health needs in the past 12 months. But at least gives us sort of an indication of those that are using the internet and those that are sort of reporting unmet health needs at some point and health information. It's the best we can do. The second data set is taking the nation's pulse on healthcare. It's an Environics survey from the Environics Research Group. And again, respondents were recruited in 2 waves by telephone, random digit dialing. It was supposed to be representative of the Canadian population, age 15 and over. This one did not include 3 territories. So all the provinces, but not the 3 territories. And the recruitment is supposed to be representative based on region, age, and gender. Male. So the sampling was done by telephone, but the questionnaires were sent out and collected by mail. So could answer the survey in either official language, and they had about a 55% response rate, which isn't bad for a mail-out survey. And this survey had about 212 questions covering, again, healthcare utilization. It was more a survey on people's satisfaction with the healthcare system, lots of questions about, with their last visit, were they satisfied, and those kinds of questions. Questions about government spending and priorities, and the future, the way people thought the future of the healthcare system should go. But there was information that we could use on health information gathering and sort of demographic and SES, socioeconomic status variables. And basically, people were asked if they were treated in the past 12 months by a family physician, a specialist, or a psychologist. And the number of visits were provided basically in had never visited, had visited 1 to 4 times, and visited 5 times or more. So in our data, it shows that as early as 2002, over 70% of the population aged 15 and over were internet users. Okay, so this may differ. This differs a little bit from StatsCan numbers, but these are individuals, and StatsCan were households. So that might answer a little bit of that. 40% of the people that used the internet claimed to use it for health-related information. And 29% of those reported using it to treat themselves. 69% reported using it as an additional source of health information other than their usual sources. And then this is for the unmet health needs. In 2003-2004, about 12% of Canadians 15 and over reported unmet health care needs. And just as a sort of sidebar, we have a huge sort of what people call the crisis now of people not being able to get the care they need. And they're talking about, you know, the numbers doubling and tripling. Well, they actually have, because back a few years before this, only about 6% of the population reported unmet healthcare needs. But the crisis is about 10% are self-reporting unmet needs at this point in time. So, sort of for our health care system, those who reported seeing a family physician, only about 20% reported not seeing a family physician in the last year, 55% 1 to 4 times, and about 25% 5 times or more. Specialists, only about 30% of the population saw a specialist 1 to 4 times, and 6.5 about more than that. And very few people saw a psychologist. 93% didn't see a psychologist at all. So for our analysis on factors associated with general internet use and the internet use for health, we first run a logit looking at the characteristics associated with internet use. Education, income, employment status, health status, age, marital status, sex. We control for year. We control for language as well, because in the surveys, anything to do with healthcare, I mean, basically it's a provincial jurisdiction, so we wanted to control for provinces. We are actually just getting that information now, so we're rerunning the analysis. But there was information on language, and the big province always, when you look at healthcare utilization in Canada, that sticks out is Quebec. So we figured by at least controlling for French, English, we sort of roundaboutly controlled for Quebec. Second step, we looked at conditional logit, so conditional on internet use. Again, what are the characteristics of users? And this time, we added the variable on those reporting unmet healthcare needs. So here, the full regression on internet use, characteristics associated with. This is the odds ratio. So a lower odds ratio, basically this means less than high school. People with less than high school education are about 55% as likely to use the internet as those with a high school education. Those with some post-secondary or college are over twice as likely to use the internet than those with a high school education. University degree, 4.5 times as likely. Okay, income shows the same thing. Those with less than $20,000 a year, about half as likely, and that basically, there's our gradient in income across the internet use. Males, here it's not statistically different for internet use in general, and those with very poor health status are less likely to use the internet than those with good health status, but the other health status indicators are not significant. Okay, so we take the individuals that claim they use the internet and ask, look at the characteristics of those that actually use it for health information. We again see some difference in education, but not as much as internet use. However, those that are more educated do tend to use it more than those that are less educated. Again, there is a slight gradient in income, but not nearly as much as was just for general internet use. So basically, you're already getting, a lot of these people with lower income are already not in this sample. And here is where although women didn't use the internet any differently than men, they tend to use it more, or men use it less for health information gathering. And those with poorer health use it substantially more than people. Sorry, I'm getting that. People with fair to poor health use it about the same. We've actually combined this measure now because people with poor health are. Let me try that again because I can't see the screen. Okay. People with poor health are about 75% as likely to use the internet as people with good health, but this sample is very, very small, so we've now combined these two. People with chronic conditions are substantially more likely to, and those with unmet healthcare needs are more likely to use the internet for healthcare, information. So this sort of does indicate that those that are not getting the care they think they should be getting in the healthcare system are turning to the internet. So higher SES is associated with higher probability of using the internet, just like all the other studies from more American data indicated. Education, again, is a key characteristic for both internet use and online health information. Women are more likely to use the internet for health information, but not general use. And those with self-reported poor health and those with chronic conditions are more likely to seek information than those with better health. And the new finding, or that isn't in the literature, is those that are reporting unmet health needs also are using the internet more for health resources. So the analysis on healthcare utilization, we used an ordered logit. We're playing around with some different estimation techniques right now. The problem is the data aren't really as we'd like them, but we've used the ordered logit for this analysis. So basically, it's no visits, 1 to 4 visits, and 5 or more visits. And then we estimate the likelihood of seeing a specialist or psychologist, just yes, no, because basically, there aren't a lot of reported visits. And characteristics are similar to the last analysis, but we use online health information to indicate whether those that seek health information are using the healthcare utilization more or less. So, okay, so these are coefficients from the ordered logit, which if it's a negative, it means that people tend to use physician less. The distribution is shifted to the left. And this is the odds ratio, the same as the last analysis. I will actually show you a chart that will make this a little bit, the odds ratios, the coefficients a little bit easier to understand. So those males tend to use a physician less than females. That's in all healthcare utilization studies show that. English, those that speak English tend to use it less than those that speak French. So again, that's sort of a provincial thing. Income doesn't pan out in these regressions, which in Canada, income tends to have a little bit of an association with healthcare utilization. Again, education tends to have a little bit of association with healthcare utilization. But we don't see it here. Marital status does. Those that tend to be single or previously married tend to use it the healthcare system less than those that are married. And those that are not employed tend to use it less than those, those that are employed or a student tend to use it less than those who are unemployed. that here could be because those who are unemployed include those on disability. So it could be a health thing. And then, as we're finding in some other research we're doing on healthcare utilization, those that are sort of young to middle age tend to be using it more than older individuals, which is not what everybody's worried about right now. And then health status is as you would think it should be. We looked at health, we tried to find some sort of health behaviors. So taking a vitamin daily was associated with higher use of the healthcare system, and as was use of online health information. So those that looked for information on the internet about health also tended to use the healthcare system more. And this goes along with the women's study that found that people that were out to find information about health on the internet used more preventative medicine. I don't know why people are using the healthcare system here, but that sort of goes along with those results. Okay, and then again, this is an odds ratio, so those that used online health information were about 22% more likely to see a specialist than those that didn't. And we kind of interpret this as those that go online and find information about different conditions and treatments available may insist more when they go to their general practitioner that they want to be referred on to a specialist. So this is the sort of chart that lets you interpret the odds ratios a little bit more easily. So this is a representative online information users. So they're male, English, university, employed. Their age is 25 to 44, income 40 to 80K, married, live in a large urban area, and they have unhealthy health behaviors. So basically that type of individual, who is sort of our base, non-online health information users see the physician 0 times, about 26%, and about 23% of online health users see the physician 0 times. 63% versus 62% see them 1 to 4, and 14 versus 12 see them 5 or more times. So the online health information users are slightly more likely to use the healthcare services than those that don't use online health information. So I've just said all that. We ran 4 ordered loaches that looked at whether the individuals who used the internet felt they were better informed on sort of, these were the questions that we could find in the survey that we thought were associated with health information. So the ingredients in the medicines they were taking, differences between medications that were supposed to do the same thing, environmental issues that affect health, and genetically modified foods. And basically, we found no association between those that online searched the internet for online health information and those that didn't, between their understanding of these issues. So, in conclusion, consumers' experiences with unmet healthcare needs is associated significantly with increased utilization of healthcare services. Use of online health information not found to be associated with a reduction in healthcare utilization, and on the contrary, it seems to be associated with a slight increase. Again, we don't know what kind of health care individuals are seeking. It could be preventative, it could be curative. And use of online healthcare system, health information doesn't seem, at least individuals are not claiming they seem to be better informed about issues that you might think were related to healthcare. Typical limitations, this is cross-sectional, so it's not a study of causality. We're just looking at associations. There's this discussion now, this whole about self-reported data in general. Should we be using it? There's lots of errors in people's reporting, but we've got lots of data out there, so I'm not sure what we do if we don't use it. And there may be unobserved factors that are associated with people that use online health information and use healthcare. We need longitudinal information to look at that. So basically, this study supports other studies found that the digital divide is apparent in Canada. Those who access health information on the internet do not feel they're better informed. Subjectivity, subjective unmet healthcare needs may be a factor contributing to increased use of people using online health information. So from where I come from, looking at policies about equity, the problem with individuals who access the internet using more healthcare resources is that this may increase the inequities in the healthcare system. So typically in healthcare utilization data, you do see inequities across socioeconomic status. So if the use of the digital divide is also increasing the use of healthcare by those that are better educated and higher income, may just be increasing the inequities in healthcare utilization. So perhaps programs subsidizing low-income families to have internet access may help in both combating a new source of inequity in the healthcare system. Thank you. Questions?
Questions? I'll just ask you, let me get the microphone to you if you have a question so that we can hear your question. I'll start out with a couple. As you know, Canada Health Infoway is in this innovation and something phase. I can't remember what it's called, in the adoption phase. And we're part of two projects, one related to chronic kidney disease, the other related to caregivers. And the issues here are so many that it's crazy. What is the relationship now between Canada Health Infoway and I know it came out of the Office of the Information Highway, and Health Canada? Is there a real exchange that occurs there so that they become aware of this type of work, or how does it work out?
There is supposed to be an arm's length, sort of, because it's not the Infoway is not a government organization, so there's sort of just this arm's length relationship. And they were, just before I left, they actually were trying to get Health Canada involved in more research, looking at areas like healthcare utilization, looking at areas like remote area access. However, last I heard, that section of the department was eliminated. So I don't know that there's any relationship anymore.
It's interesting because we're finding out that very fundamental things issues do not appear to be represented in the projects that Infoway is undertaking. And issues like we've identified here. And without those being identified, the projects have potentially no value or restricted value. And I think there's a beginning of Infoway's looking to the research community, but only a beginning in that regard. Have you had any experience with this yourself?
I don't know how much. Not from my time at Health Canada, but from my some of the reading I've done on the subject. it seems like the first vast amounts of money and time were spent in just getting the technology. So not really looking at some of these other issues. It was just getting the technology, trying to get it up and going, and the whole idea, the complicated. I don't know that much about computers. I know how to push the buttons on them, so I'm not that literate in it. But from the reading I did, it was about the technology. There wasn't a lot of evaluation done. Like there were problems like, there were computers being put on physicians' desks and in hospital wards, but nobody turned those computers on because they didn't know how to use them. So, yes, they were getting the technology out there, but there was a problem with the user end. So those were kinds of issues that were starting to be addressed when I left Health Canada. How do you get, typically middle to older, the younger physicians, it's not a problem. It's the more experienced, the older, typically male physicians that there's a problem.
So it's the adoption by the providers. Well,
Yeah.
Some of the projects are now moving in the direction of user, the patient, if you want support. And where adoption becomes into the issues that you're dealing with here, who has access, do you have the digital divide, and so on. It's just interesting that there is so little in the process that deals with that part of it. We're just meeting last night with a group of people who are interested in personal health records. And the big issue is, do patients want personal health records? And if they have a personal health record, how will they use it? What effect might it have? The government seems to make the assumption, which I think you're finding, what I would expect is that the government makes the assumption that these systems will actually reduce utilization, but in fact they may increase and make people more aware of it. But that seems like the assumption is an incorrect assumption.
Yeah, some of the other interesting things I found when I was doing the reading in this area is it's not just computer users that look for health information. There was one study that looked at everybody owned a computer, either at home or at work, so they were fluent at some point in using computers. But it was only the people that actually actively used email and those kinds of things that used the computer to find information. So there's a big difference between, people having a computer, and like my father does his taxes and follows his money on the stock market and does all that kind of stuff on the computer, but would never do a Google search, wouldn't have any idea. You'd say, go look online for that, and he'd say, what do you mean look online? So I mean, there's a big, all those kinds of things have to be taken into consideration. And I think the socioeconomic status is a huge problem. I mean, so it's not just whether or not, those people that have computers, there's sort of only a subsection of those that use it for health information or other areas of health, but all those individuals that don't have access at all, and those tend to be the individuals that probably should be having some access to health information.
Make sure people.
Is there any sense at all of the depth of research that people are doing on the internet? Like, is there any kind of a differentiation between just the casual person who has a thought and goes on and just looks up, what a particular disease means, as opposed to somebody who's really seriously researching, downloading a lot of stuff, trucking it along to their doctor's office?
This is the economist in me coming out. I actually did find a couple of qualitative studies, but because I don't know the methodologies used in qualitative studies as well, I don't know how valid they are. But there are qualitative studies coming out looking at more kinds of the quality of information on the internet, the kind of information people are finding. I can't tell you off the top of my head what the actual results were.
I have just a comment, and I found it interesting that one of the barriers to the use of the information, healthcare information, was the level of language that was used on the sites that are now available. We're involved in another portal development where the level of language has been a huge issue, and we keep trying to simplify the language. I'm not saying that to dumb it down, but to make it easy for anybody to read. And it's not an easy task. There are all sorts of ways to identify the level of language that you're using, but to get it from a grade 11 to what we think we need, which is a 6 to grade 8 level, to 6 preferably, takes a lot of work. And I'm not sure that the premier healthcare sites that we would be going to would even be at that level, or would even be thinking about trying to do that.
Yeah. Well, there's two issues there. I mean, I think a lot of the health information sites would not be at, the level needed for people with low levels of literacy. And then do those people with low levels of literacy, can they actually get onto the internet and use it? Now, I know my kids were using sort of computers and the internet at quite a low grade level. I mean, they're introducing them in the schools almost right away now. So that may not be an issue in a few years, but perhaps now.
I'm sure people have questions. One of the, we're working with Gina Brown at McMaster, who's done quite a few things now related to motivation and motivating behavior and so on. We're transporting that into a portal environment. And the other factor, when I was looking at your data, I think it would be very interesting, when I'm getting to it, it'd be very interesting to do a design of a survey rather than looking at existing data.
Yeah.
I mean, there are aspects that you want to ask, and that might be something that there might be a group of people here interested in. Gina's found that from her work that depressed patients are have high levels of utilization of the health system.
Yeah, well, the one study I looked at found that patients with depression and anxiety were, I mean, in general, sick patients tend to use it more than healthy people, and within that group, people with depression and anxiety were more likely to use it than
when we're engaging patients, it's another factor, like we're looking at this caregiver portal that we're working on, which is trying to assist people who are taking care of their parents under perhaps the guidance of a professional caregiver, but working quite independently. And it turns out that 60% of them are depressed.
Oh yeah,
so depression plays a big factor, not only in the other fact I need there is that depressed people tend to not want to use technology. So you've got the high utilizers being depressed people who tend not to want to use technology, but in order to have an impact, you're going to have to engage them. So a huge problem is that the state of the patient affects the utilization itself.
Well, and it also is the fact that most caregivers of elderly parents anyway are getting to be people my age and tend to be women. So there's those factors as well. Older people tend to use the internet less than younger people. So there's lots of issues that have to be addressed. I mean, I think the number one thing is that we need to know the characteristics of the people that are using the internet and using it for health information, and go from there.
And the portal itself, or the technology itself, needs to take those into account, because one of the things we're finding in these systems, they're ineffective. I mean, overall, these systems have very little despite years and many clinical trials, there's very little overall effect, that you can find. Well, part of the reason is they're misdesigned. I mean, that's really, they're not dealing with the human factors of the people actually using them, like age and socioeconomic level and depression and things like that. No wonder that it doesn't turn out to be successful. These other factors seem to deviate the people from using the system in a way that is successful. The other thing I wanted to mention is, well, Jose Arocha here has done some work in the issue of understandability of information in applied health sciences. There's a number of people here that are interested in that. And another area, physicians in becoming frustrated with the net would like their patients to use it more properly, because they come in very wise, but not, very knowledgeable, but not necessarily very wise, and drive them crazy, the feeling. But there's a movement towards, they call it information therapy, IX. And there have been several conferences now on this, where the physicians are creating or helping to pull together information that they then prescribe, literally in a script, to the patient, where they've got some control over that. At Brigham and Women's, now called Partners, they have a similar thing in terms of information. They have a group of people that look at clinical information and decide which of it is important. So that this problem of the types of information and the misinformation and the ununderstandable information gets overcome to some degree by the intervention of the providers, if you want, directly in the choice of that information. That's something else. The question there still is it effective? And I don't know the answer to that. But there's a fairly big operation in Eastern Canada Michael Ginn has developed related to this information therapy. He's actually got a commercial system he's putting onto the market.
I mean, that's interesting because it certainly shows that, at least the stuff I read showed that, number one, people want information from their healthcare providers. So if the healthcare providers are sort of taking a lead in pointing people to the correct sites, then that's probably, a good thing. They get sort of the information from the healthcare provider, and they're also going to, better, I guess.
It's got a lot of positives. It actually recommends they're becoming knowledgeable rather than reacting negatively to the knowledge they come in with. But it makes sure they get the right knowledge, and perhaps better engages the patient in the process. I don't know, but I don't know that that's been evaluated thoroughly yet. But
well, I think that's the problem with a lot of these things. I don't think there's been some sort of, like I said, correlational studies, but I don't think there's been any that I saw any like really good evaluations on. There were some evaluations on sort of telephone and internet use instead of going to emergency rooms kind of thing in the States, but not a lot of sort of big-scale evaluations at all on any of this, although we're spending tons and tons and tons of money on it. And like I said, I think the government's assumption was always that if people have better information, that they can access through the internet, then that'll keep them out of emergency rooms, that'll keep them out of their doctor's office.
there are two worth looking at. There's a thing called Baby Care Link in the United States, which has been thoroughly evaluated, which has shown very significant effect in your area of women's issues, very significant effect on neonatal health, both of the mother and the baby, and also on another one developed at St. Jude's. Yuri, I can't remember his last name, from London went to there and developed a system. They're evaluating that. That's used largely in developing countries. With a very strong orientation toward specific problems, of those countries and the types of diseases and so on. These seem to actually be having a salutary effect.
Well, I know when I was at Dell, they were actually using the internet and the computer sort of generated, lab and X-rays and stuff. To actually send information back and have the specialists at the Faculty of Medicine look at things and sort of go back and forth between physicians in underdeveloped countries and physicians here that had sort of more information.
Yeah, in these cases, they're actually the patients and the mothers and children and so on, mothers in the case of neonates, but are using it directly, and it's meant to be an augmentation to the care. Yuri Quintana is the one at St. Jude's, and that's remarkable work. We just saw a presentation at a conference in Victoria a few months ago. But a lot of interesting stuff going on. But the big message is that there's an awful lot that isn't known, and I guess the question is, are any of the data sources really adequate, or do we need to do ab initio surveys that really get into these questions and get some real answers?
Well, and particularly if this is to reduce the utilization of health care, but huge pockets of those people that could benefit most either have no access to that information, so we're creating more of a digital divide situation, or that people with chronic disease and are older may not be even interested, even if they do have the skills to do it. So
some recent data from Grand River on their My Care Source portal, we just heard that today, is that only 20% of patients agreed to get on that. This is women with breast cancer and in the treatment phase, and only 20% of patients were willing to get on it. And of those, only 60% actually used it. So that's 12% we're down to of a very interested, very threatened population of people. it's very difficult to reach people when you're not getting them.
Yeah.
You know, there's more than just a digital divide. There is not a tendency to see this technology as a health intervention, which I think is actually even worse than the digital divide, because even people who could access it don't.
Yeah. Well, I mean, for years we couldn't even get people to go to nurse practitioners rather than a physician. So, you know, I'm kind of skeptical that you're going to get people to go to the internet rather than, you know, seeing someone face to face.
Interesting. Well, any final questions or comments? Thank you very much.
Mm-hmm.